Welcome to part 2 of module 1. I love this idea that you need to be the leader you would follow. I think that is how we can think about our own personal accountability and understanding that as a nurse leader, again, whether we're a bedside nurse leader or whether we're an executive nurse leader, that we need to create the type of personality and work behaviors and belief systems that inspire others to want to follow us. As we go into part 2 that really deals with the coordination of patient care, this really gets to the heart of the multiple roles that nurses play in coordinating care. And when we think about coordinating care, I want you to be thinking about the nurse as a bedside nurse leader. Coordinating care is a leadership responsibility. One of the steps in coordinating care is understanding decision-making styles. There are 4 that ATI addresses as well as your textbook, and they are decisive, flexible, hierarchical, and integrative. Just like management or leadership styles, decision-making styles need to be flexible as well. You need to be adept at using all of these in the right situation. Know which style you gravitate towards, and then begin to polish and fine-tune the ones that maybe you're not so great with. A decisive decision-making style means that you use minimal data, resulting in one decision. So it's kind of one of those on-the-fly decision-making styles. Flexible means that you have limited data resulting in several options. Hierarchical is lots of data and still one option. So you get lots of opinions, lots of ideas, and you come up with one best solution. And then an integrative decision-making style is when you come up with a large amount of data and lots of solutions, several options. So in varying situations, any of these decision-making styles would be appropriate. The important step for a new nurse leader is to understand what their own style is and to polish and fine-tune the other styles so that they have some flexibility in decision-making. Related to decision-making can be done centralized or decentralized. Centralized decision-making occurs at normally it's an executive or management level. The centralized decision-making has a big picture approach and understands what equity would look like for the larger population of the larger organization. Decentralized decision-making is more practical, but tends to be more narrow. Decentralized decision-making is when decisions are made at the point of the problems occurring. So think about staffing, for an example. You can have a centralized type of decision-making related to staffing so that you have one place that does staffing for the entire hospital. You can have decentralized decision-making, so each of those units decide how they want to handle staffing. One has a big picture, which would be central decision-making. They understand the whole house picture of staffing, whereas decentralized decision-making can be very precise in meeting its own staffing needs, but may actually be short-sighted and not aware of the other staffing needs throughout a hospital system. Again, there's pros and cons for both types of decision-making locations, but we have to understand the strengths of and weaknesses of both. Regardless of whether you're using a centralized decision-making or decentralized, you need to talk to your stakeholders. You've got to talk to anyone that's being impacted by the decision that's being made. We think about change. When we're making decisions, we're going to change something for somebody, and the strategies we use to inspire other people to be agreeable to change are strategies. What I'd like you to do is be familiar with these 3. So a rational empirical change strategy has the style that if the person trying to inspire change or create change uses an argument with lots of rational data and it's presented in an effective manner, the group or the person that's being influenced to change is going to change because it supports their own interests. So understanding the people that you're talking to and getting their buy-in by giving a rational data set that is relevant to them is the rational empirical method of change. A normative re-educative change is when change is motivated when the individual identifies some level of dissatisfaction with the status quo and is unhappy. And then the key task of the person influencing the change is to find a way to offer them change that relieves the dissatisfaction. The normative re-educative normally has a peer relationship involved. So it's a colleague to colleague communication of, this isn't going well, so let's try this. My idea is better because, look, you're already unhappy with this, so this would make you happier. So again, it's a peer level influence. Power coercive change strategy looks at using politics or an economic sanction to bring about change, to kind of force someone into change, either through creating shame or embarrassment or some kind of sanction that is pretty public, and it's based on power or a power relationship of someone being in power over someone else. So that's very different. So I want you to think about kind of how you would go about change and what your comfort level is with change, and think about how you would use these strategies effectively. These are the stages of group process, and it's important for you to know these. ATI likes them, and so does NCLEX, because they're real. They have been around for decades, and we know that most group processes form in these steps. So when the group is forming, that's when they're meeting each other. They're getting to know each other, figuring out who everyone is, what their personalities are. The storming piece is establishing a group identity. It's the pushing and pulling, the negotiation that occurs with coming up with the roles you play and figuring out what each work product the person will work on. Norming is when the group establishes roles and designs the work. This is where they set up the goals. They say, this is what we're going to accomplish. And then the performing is then when the work actually gets done. Sometimes a fifth step is included, and that's the termination step. The termination step is included when the group is designed for a specific purpose, and when that purpose is done, the group has to close. And the termination is when you reflect over the goals, you talk about how it went, and then you celebrate your successes. You acknowledge, that things are going well and that you accomplished what you set out to do. The forming and storming roles or phases tend to be the ones that tend to be a little bit more tumultuous, because when you're forming your groups, you really are trying to figure out who everyone is. Whereas the storming piece, as it implies, has the most level of conflict, because that's when everybody is trying to figure out what role they're going to play within the group. It's where a lot of the power struggle goes on, and that's when ideas that are new and maybe uncomfortable for people are expressed. So the churn that happens in storming is essential for the norming part of the actual design of the work and the work to be done in the norming and performing stages. Very often groups will come together and they'll say, okay, this is the project and this is how we're going to do it, but they don't back up and deal with the uncomfortable phase of the storming phase, when everyone is really doing that push and pull and that finding where they're going to fit in the group. So I want you to think about these and be familiar with them. From a workforce standpoint, we want to make sure that we have diversity within our workforce, and that's not just age diversity, but also cultural and ethnical diversity. So the value of having a diverse workforce is our ability to provide more sensitive care to the patients that we provide care to. So if you think about the vastness that diversity provides us, it should replicate the diversity of the patients that we're providing care. We are much more likely to give culturally sensitive care if we are a diverse staff across age, gender, ethnicity, and culture. So when we're hiring, when we're recruiting, when we're pulling in teams, whether it's a full staff or whether it's teams for small work groups or committees, we want as many different perspectives as possible, not just ideas, but backgrounds and life experiences as possible. It creates a richness that really allows us to develop good ideas from multiple perspectives. Another reminder about Magnet, we talked about that in Module 1, so I won't go too much in depth. What I want you to be mindful of is that Magnet hospitals are very focused on nursing excellence. They want well-qualified nurse executives. They want nurses who are autonomous, who work in a shared governance or participatory management style. And then they want a culture that really focuses on quality of care. And that's an important element when we are thinking about our outcomes, that we are thinking about what's the best kind of nursing care we can provide. If we think about the role of the nurse leader in the role of a case manager, historically a case manager could be anyone that had experience in a certain service area. There's discussion now about making a case manager an advanced practice role where you could actually need a graduate degree to work in case management. Not all hospitals have adopted that because, quite frankly, it's expensive. But case management is an important higher level role for nurses because what they're doing is they create a collaborative process that coordinates a care for a patient during an episode of illness. So from the time they are admitted till the time they are discharged and through their illness. So they may be discharged home for home care. The case manager follows them not through their placement of care, but through their entire illness. So a case manager could assume a case at the beginning of coming in for open heart surgery and follow them through cardiac rehab in the outpatient setting until they're discharged. That's a lot of responsibility. It is important that we think about case management and we understand the goals of case management. So the case management's primary aim is to increase functioning and efficiency, and we want to increase or improve the quality of life and the cutting back of resources. So how do we make sure the patient gets what they need and they have a quality outcome, but that we do that in a cost-effective manner. So the end result of being efficient in our care is that money is saved. Organizationally, a lot of hospital systems have put in a lot of money with case managers because they feel like if patient care, especially for complex cases, is stewarded through the hospital system and then out through outpatient, they are more effective and more efficient in their care. They get discharged sooner, they have better outcomes, and they're less likely to come back into the hospital consuming more services. So money is saved as a result of improved quality and improved efficiencies. Managing care with case managers. An element of case management is understanding that many case managers use a multidisciplinary action plan. And a multidisciplinary action plan is like what nurses call nursing care plans. This is actually a combination of a critical pathway, which is the interventions for medical care, and then a nursing care plan. And they're dovetailed together to provide a comprehensive care plan that covers all of the medical components, all the steps through an illness and the treatment, and then how the nurse will intervene throughout each of those episodes. So the idea is that the multidisciplinary action plan or the MAPs are more coordinated, and because they're coordinated across disciplines, that there's efficiency and efficacy through that process, and you save money. If a patient deviates from the normal plan, so if you have a patient who comes in for a cardiac cath and the critical pathway says they go through step 1, step 2, and step 3, well, they don't get out of step 2 in the time frame that they were supposed to, that's called a variance. So we know that the patients don't read our textbooks. They don't read our critical pathways or our nursing care plans. They kind of do their own thing. And sometimes patients step outside the variance, step outside the plan, and they become a variance. When variances happen, this is when there can be an expense that is unplanned. Real brief, this is the critical pathways and the explanation of the critical pathways. Again, I remind you, patients don't read the pathways. They don't read our nursing plans. They kind of do what they're going to do. So we have to be prepared to handle the variances when they happen. We cannot prevent variances, no matter how well we control things. The human body is the human body, and patients are going to do what they do. We have to be prepared to manage variances that occur. So just to review, a variance is anything that occurs that alters the client's progression through the critical pathway. Variance tracking involves documenting when and why patient variances occur. So the value of tracking variances is when a variance occurs, we need to know why the variance happens. And through researching and studying when patients don't fall in line with critical pathways, we can alter and update our critical pathway or the MAPs, or we can recognize that there's a trend or a pattern that we need to address, and that the MAPs are fine. It's that there's something different going on in our patient population, and maybe we needed to address it from a different angle. So I want you to be familiar with that. So SBAR again, I know that you've seen this again. Once again, ATI brings it into chapter 2. Again, just reminding you, it's a structured, orderly approach to providing accurate, relevant information in emergent patient situations. It is valuable in handoff communication as well as cross-interdisciplinary communication. One of the things we found, if you look at the research about using SBAR across disciplines, so nurses talking to physicians, nursing talking to respiratory therapies, using SBAR in a group huddle, what they found was that it was a huge time saver and it improved the accuracy of information being given. So it's important that we're familiar with it. Common features, we think about roles of nurse leaders in managing care. We talked about case manager. One of the new roles for nurse leaders to function in is in the role of a disease management program. The disease management programs are different than case management, so I want you to be familiar with disease management. Disease management provides a comprehensive, integrative approach to care and reimbursement of common high-cost chronic illnesses. So this is specific to chronic illnesses that are expensive. Think about cancer. And yes, cancer in 2019 is considered chronic. Diabetes. High cholesterol, hyperlipidemia, asthma. Chronic otitis media, interestingly, is on that list because kids get chronic ear infections and it creates all sorts of issues for little ones that can actually result in hearing loss and then speech deficiencies. And then we have developmental milestones that aren't being met, so that has become an issue. I think I said COPD, strokes, all of those land in this bucket. The idea is to focus on high-risk people who are at risk for diseases, as well as early detection and early prevention. The disease management is very much focused on a population outcome, and it is extremely expensive. The idea is if we put in the money towards managing identifying an early treatment for specific chronic diseases, is that the long-term expense for the person over a lifetime will be decreased. So we put the money in on the front end, so we spend less on the tail end dealing with it as a chronic disease. It's a very complicated process, but it is one that's emerging and one that nurses are functioning in. The last one I want to talk to you about is a clinical nurse leader. I'm sure you've probably been made aware that the USC Upstate has a graduate degree for clinical nurse leaders. It is for a little while people were thinking it was kind of like the clinical nurse specialist, but it really isn't. It's its own clinical nurse leader role. It is a graduate degree. The idea is that the nurse will act as a clinical leader at the bedside. So this isn't someone that is in the office managing staffing and managing personnel issues. This is the one that's at the bedside talking about coordination of care, talking about how best to use patient beds. They're the ones bringing in evidence-based practice. They are the go-to person for, hey, we've got a research project based on outcomes for diabetes education. Let's sit down and talk about this. They're your go-to people for these kinds of research projects, really infusing evidence-based practice in at the bedside in a very focused manner. The other one to throw out there that's not on this list, but another role that the bedside nurse leader is functioning as is a nurse navigator. It's a relatively new role. Nurse navigators help patients and family navigate the healthcare system. They are very commonly used in the patient-centered home. It's part of the Affordable Care Act umbrella where that role is being used. It's crossed over into the case manager role, and it has a little bit of disease management. It is not a well-defined role. The nurse navigator role, but it is a phrase that's used when you think about the patient-centered care or the patient's medical home. So that is it for Module 2 or Part 2 of Module 1. I hope this has been helpful in guiding some of your reading and answering a few of your questions.